Okay, this is Kay Afji, and I'm continuing the recorded lecture for now for nursing care of patients with head and spinal cord injuries. Oops, sorry about that. Okay, first of all, for brain injuries, a blow to the head may cause either a laceration of the skin or scalp and a fracture of the skull, or it may only cause a minor contusion to the brain. The injury may cause movement of the brain within the skull, tearing blood vessels and then causing hemorrhage. Falls are the most common cause of head injury, with then motor vehicle accidents coming in second as a major cause. For pathophysiology, when a depressed skull fracture occurs, there is bruising, contusion, or laceration of the underlying brain tissue that causes inflammatory changes as it would with any type of wound. A minor head injury may cause a concussion. A concussion is a closed head injury in which there is a brief loss of consciousness, amnesia regarding the occurrence, and also a headache. The concussion's seriousness is based on the length of time there was a loss of consciousness. There could be long-term neurological effects from a concussion, especially if the person sustains repeated concussions from accidents or from sports injuries. Skull fractures are described as linear or depressed, simple, comminuted, or compound, closed or open. If it's an open injury, then there's a laceration of the scalp and a fracture of the skull with damage to the brain tissue. A closed injury is one in which the scalp and skull remain intact, but there is brain tissue damage. In closed injuries, a very serious condition known as increased intracranial pressure may result. And we kind of talked about the increased intracranial pressure when we talked about assessment of the neurological system. In a contusion, the brain tissue is bruised, blood vessels have broken and blood accumulates, and edema develops. And this can cause an increase in intracranial pressure. A coup-contre-coup injury, or an acceleration-deceleration injury, occurs when the head is moving rapidly and hits a stationary object, such as in a motor vehicle accident if the head would hit the windshield. So the contents within the skull hits the inside of the skull and then bounces back and hits the bony areas on the opposite side of impact, causing a second injury. Subdural hematomas are common types of head injuries, and they often happen in older adults as a result of a fall. A risk factor for elderly is that many of our elderly are on anticoagulant therapy or aspirin types of therapy, which puts them at greater risk for hematomas, even if they just sustain just a minor blow to the head. When a blow is delivered to the head, it can rupture the blood vessels that lie between the arachnoid meninges covering the brain and the dura mater, the outer covering of the brain. And as the blood leaks under the dura mater, the hematoma can grow in size, pressing against the brain tissue as well as its covering. Okay, an epidural hematoma occurs rarely, but when it does, there's a rapid leaking of blood from the middle meningeal artery, which can quickly elevate the intracranial pressure. This, of course, would constitute a medical emergency, and a craniotomy, partial removal of the skull, is needed to repair the damaged vessel and to relieve the increasing intracranial pressure. And then an intracerebral hematoma occurs within the brain. It can often occur as a result of like an aneurysm that ruptures or a blow to the head. Okay, signs and symptoms of brain damage is basically based on the symptoms presented by the patient, a neurological assessment, and the history of the type of blow that the patient received to his head, and whether or not the victim lost consciousness. Outward symptoms could be bruising, swelling, laceration, and bleeding. There may be a skull fracture, and this is indicated by ecchymosis around the eyes. They call that raccoon eyes. Or ecchymosis behind the ear, otherwise known as a battle sign. There can be fluid leaking from the ear, fluid leaking from the nose, ringing in the ear, or hearing difficulty. There could be paralysis of the face. There could be a deviation of the gaze. If there's drainage from the nose or from the ear, it should be tested to determine if it's a cerebrospinal fluid leak. If there's bleeding in the subarachnoid space, that can be evidenced by neck pain with flexion of the neck, otherwise known as nuchal rigidity. If there's a moderate or severe head injury, the cervical spine injury should also be assumed, so the patient should be positioned carefully and keep the vertical or the vertebrae in alignment. Let's see, a concussion may cause a brief disruption of level of consciousness and amnesia regarding the event and a headache. A contusion may cause alteration in level of consciousness and may cause seizures. If you look at box 22-1 on page 502 of the textbook, it will show the downward progression of decreasing level of consciousness. So you would see alert patient responds appropriately to questions and commands with little stimulation and attends to surroundings. Confusion, the patient may be somewhat disoriented to surroundings, time, or people. Their judgment may be impaired, and they need to be cued to respond to commands. Lethargy is being drowsy but easily aroused, just needs gentle touch or verbal stimulation to follow commands. Obtunded is more difficult to arouse and responds slowly to stimulation, may need repeated stimulation to maintain attention and to respond to the environmental surroundings. Stuporous is where the patient responds to vigorous stimulation only slightly, may only moan or mutter in response, and then comatose is where there's no observable response to any stimulation. A subdural hematoma may be acute, subacute, or chronic. An acute intracerebral bleed causes a hematoma to form, and if it's accompanied by unconsciousness and hemiplegia on the opposite side of the injury and a dilated pupil on the same side, these symptoms indicate a slow buildup of pressure within the skull. Signs of epidural hematoma may include unconsciousness at the time of injury, brief oriented periods followed by decreasing level of consciousness, and dilation of the same side of the injury pupil. Diagnosis is made. The tests that are done would be an X-ray of the skull to check for fractures, a CT scan, an MRI with contrast, or a PET scan, and then finally an EEG to determine brain activity. Treatment of a head injury. Initially, they may be treated conservatively if there's an increase in intracranial pressure, or if there's a compound fracture of the skull. The patient may have surgical debridement of the wound and removal of splintered bone from the brain tissue. A patient's airway should be secured, and the patient's head of their bed should be raised 20 to 30 degrees with the body in, of course, correct alignment. Elevation helps to reduce the intracranial pressure. At that time, of course, we need to monitor their neurological signs. An IV would be inserted so the patient can have diuretic drugs to help bring down the swelling in the brain if necessary, and also for administration of IV fluids. IV fluids are usually infused slowly because we want to prevent fluid volume overload, because that, of course, would increase your intracranial pressure. Diuretics can be used, like I said, to decrease vascular volume, decrease swelling, and help keep the intracranial pressure as low as possible. If the patient has a subdural hematoma, then they would be a candidate for surgery. And the hematoma is removed either by burring holes into the skull or by removing a portion of the skull bone to get to the hematoma. Then the hematoma is suctioned or removed surgically out of the skull. Like I say, the epidural hematoma is an emergency situation. Because of the increased intracranial pressure, it will cause brain damage and possibly death. Okay, following the surgery, the immediate post-op period for a patient who's undergone craniotomy, patient, of course, would be in an intensive care unit so they could be continuously monitored. The patient would be positioned, of course, according to the written orders from the attending physician. You need to make no exceptions to the orders. Positioning is important to prevent increased intracranial pressure. The patient needs to have his neck in midline, and there should be no excessive hip flexion because we want to promote the venous drainage from the head and keep the intracranial pressure from rising. There should be nasal suctioning only if there's a written order for this, because there may be a fracture that allows a pathway to the brain tissue, so you could possibly be passing that suction catheter into the brain tissue and cause damage. Nurses should watch carefully for signs of leakage of cerebrospinal fluid from the nose, ear, and operative site, and report any leakage immediately. Nurses must use aseptic technique in applying dressings to catch the drainage and prevent microorganisms from entering. The nurses should provide a quiet, non-stimulating environment for the patient to prevent overstimulation and administer only treatments, comfort measures, and medications for which there are specific written orders, and report any changes in neurological status promptly. If there is a leakage of cerebrospinal fluid through the nose, ear, or open head wound, special precautions have to be taken. These precautions include absolute bed rest, with the head of the bed elevated 20 to 30 degrees to promote venous drainage from the head. Cover a draining ear with sterile gauze changing the pad periodically to look for drainage. Instruct the patient not to blow his nose or pick at it because blowing can increase the intracranial pressure and picking may allow entry of microorganisms. Do not block or plug the nose or ear if there's drainage of CSF because blockage may increase intracranial pressure. And remind the patient that he is not to change his position in any way unless he has been told it's okay to prevent intracranial pressure from rising. And then of course we would continue to do the neurological assessments as noted previously. Okay, now let's take a look at injuries of the spine and the spinal cord. A person can suffer an injury to the spinal cord in a number of different ways. Automobile accidents, gunshot wounds, diving accidents, and other forms of trauma can inflict damage to the spinal cord. Tumors, degenerative disease, and infection can also impair the function of the spinal cord as well. Generally, spinal cord injuries are classified according to their anatomic location, so cervical, thoracic, lumbar, or sacral. The amount of loss of function and sensation depends on the level and extent of the injury to the spinal cord. So there can be fracture, dislocation, or subluxation, which is the partial dislocation of the vertebral column, and this can result in spinal cord damage. Cord injury can be caused by compression, pulling and twisting, or tearing of the cord. There are two types of injuries that can occur: complete and incomplete. Complete injuries result in loss of function below the level of the injury. Incomplete injuries result in various degrees of function and sensation below the level of the injury. Penetrating trauma like that caused by a gunshot or a knife wound may cause severance, compression, or contusion of the spinal cord. Extreme flexion or hyperextension of the neck or falling on the buttocks may cause spinal cord damage as well. Tumor growth can compress or destroy spinal cord tissue. But whatever the cause of the injury, nerve transmission to the brain and from the brain may no longer occur below the level of the injury. Microscopic bleeding occurs in the gray matter immediately after a spinal cord injury. Irritation of the cells then causes edema to develop, and the edema usually peaks in 2 to 3 days and subsides in about 7 days after the edema. This edema causes a temporary loss of function and sensation. It may cause a drop in blood pressure that can also decrease blood flow, and hypoxia in the cord increases the initial damage. Inflammation can injure the myelin covering of the axons as well. Signs and symptoms of a spinal cord injury is that it results in a total loss of sensation and control in parts of the body below the point of injury. So if the cord is damaged in the cervical area, paralysis and loss of sensory perception may include both arms and both legs. And this is called quadriplegia or tetraplegia. Severe injury to the cord above the level of the 5th cervical vertebrae is usually or often fatal if emergency care cannot be provided because it affects the nerves that innervate the diaphragm, which assists in breathing. Interruption of the thoracic spinal cord through L1 and L2 causes paraplegia, which is paralysis of both legs. And if you look at table 22-1 on page, let's see here, 512 of your textbook, you can see the activities that are possible with varying levels of cord injury. If the injury to the spinal cord does not involve complete severance of the cord, it may result in temporary paralysis, which subsides as the spinal cord recovers from the swelling and the initial shock of the injury. Diagnosis is made by physical examination and testing of the reflexes. A CAT scan or MRI can be done to determine the extent of the damage and see if the cord has been completely severed or transected. And treatment, there are four main objectives of treatment when the spinal cord injury has occurred. I'm going to go through those now. Save the person's life. Prevent further injury to the cord by carefully handling the patient. Repair as much of the damage to the cord as possible. And then establish a routine of care that will improve and maintain the patient's state of health and prevent complications so that eventual physical, mental, and social rehabilitation is possible. I just wanted to show you a couple of treatments that patients, especially with cervical dislocations or spinal cord injuries, can have initiated to keep the cervical spine immobilized. The first one you see here is the Crutchfield tongs used for cervical traction. And in this case, the patient, of course, is bedridden. The pins are inserted into the skull, and then the Crutchfield tongs are applied, and then the weight, which is located at the top of the bed, then hangs freely and applies pressure to keep the cervical spine in alignment. Another type of traction for cervical spine injuries is called a halo traction vest, and this also is used for cervical spine stabilization. As you can see with this type of apparatus, the patient can be up and be more mobile. They're not tied to the bed. You can kind of see there's the rigid shoulder straps on the encompassing vest. The vest comes in various sizes for different size patients. And the nice thing about this is the vest is actually magnetic resonance imaging compatible, so if the patient was going to have an MRI, they could actually keep this apparatus on, which is kind of interesting. And again, you can see that it keeps the cervical spine in alignment, but the patient then is more independent. Then this example is Rotorest Delta Advanced Kinetic Therapy System, and this helps in repositioning the patient, because again we have to keep the patient in perfect alignment so to prevent damage to the injured spinal cord. So this bed will tilt and reposition the patient even without, rather than having the staff trying to reposition them and getting them out of alignment, this bed kind of allows the patient to be positioned to be changed. Okay, and then we have, briefly again, I'm just going to refer you to table 22-1 to look at the level of spinal cord damage, function present, and activities possible, just to give you some idea of, where a location of an injury would occur, what they would possibly be able to still function at. Okay, so nursing management of a patient who has a spinal cord injury. Of course, the first thing we're concentrating on is the respiratory system, the patient may be intubated and placed on a mechanical ventilator with an injury of C5 or above. Patients with an intact phrenic nerve may receive a phrenic nerve stimulator that assists them to help them breathe by stimulating the nerve to innervate the diaphragm so patients can breathe without the assistance of a mechanical ventilator. Then we have immobilization and surgery. Surgery on the spine is done to remove bone fragments and relieve pressure. It also can be done to provide stabilization and prevent any further injury. Cervical spine cord injury is usually treated with traction first to immobilize the affected vertebrae and maintain alignment. Then we look at the types again of traction that are applied. You can either have the Crutchfield tongs, or you can have the halo traction applied. Patient might be placed in a road arrest bed like we talked about before. Then we're managing their urinary output. They may have an indwelling catheter inserted to prevent bladder distension. And after a week or so, the patient will be started on a bladder management program. Psychological care, of course, there's short-term and long-term psychological changes that is brought about by the paralysis. So referrals may need to be made to attend to the psychological stress and deal with the changes that are going to occur following a spinal cord injury. As far as grief and mourning response, there may be permanent neurological deficits, and with that, the patient may experience many type losses. So they, of course, will experience grief and mourning, and will go through the stages of grief and mourning, just as they would for any type of loss: the shock and denial, anger, bargaining, depression, and then finally the adjustment or acceptance. If they have sexual concerns, they may also be then referred to support groups or someone or counselor. Females who have spinal cord injuries can still become pregnant, so that is still a possibility. Complications of spinal cord injuries: spinal shock and neurogenic shock. So spinal shock is characterized by a flaccid paralysis and a loss of reflex activity and sensation below the level of the injury. It occurs immediately after the injury and lasts approximately 48 hours to several weeks. We never really quite know how long it's going to last. Neurogenic shock occurs within 24 hours and is caused by the loss of vasomotor tone and is characterized by bradycardia, hypotension, venous pooling, decreased cardiac output, and occasionally paralytic ileus. The vital signs can be extremely changeable. Treatment is aimed at maintaining an adequate blood pressure and heart rate. And we find neurogenic shock occurs with a cervical or a high thoracic injury. Immediately after a spinal cord injury, the patient usually will have a flaccid type of paralysis due to the spinal shock. But as the cord adjusts to the injury, the paralysis can become more spastic, and there will be strong involuntary contractions of the skeletal muscles. Patients and families often see the spasms as a return of voluntary function of the limbs and have false hopes that the patient's going to have a complete recovery. So the nurse has to explain to them that the spasms are common in patients with spinal cord injuries. To avoid stimulating the muscles when moving the patients, avoid grasping the muscle itself, use the palms of the hands to support the joints above and below the affected muscles. And antispasmodic medications such as baclofen may actually be ordered as well to decrease the severity of the spasms. Autonomic dysreflexia or hyperreflexia is an exaggerated reflex response of the autonomic nervous system to a form of stimulation, and it usually occurs in patients who've had spinal cord injuries at or above the level of the 6th thoracic vertebra. The autonomic dysreflexia response is dangerous to patients because it can cause vasoconstriction of the arterioles with an immediate elevation of blood pressure. So the sudden hypertension can cause a seizure, retinal hemorrhage, or a stroke. Other symptoms include a severe headache, changes in pulse rate, sweating and flushing above the level of the spinal cord, and pallor and goosebumps above the level of the injury. Like I said, AD occurs most often in spinal cord disorders at or above T6 level. What can precipitate autonomic dysreflexia? Tight clothing around the waist can elicit a response, but most episodes of autonomic dysreflexia are associated with bowel, bladder, and skin problems. So if a catheter is kinked, the patient's bladder becomes distended, or if the patient becomes impacted, or if there's a sudden change in positioning, these can all result in autonomic dysreflexia. So for the nurse, it's important to keep the bladder from becoming distended, keep the patient from becoming impacted with stool, and make sure that the skin it remains intact, that there's no sign of breakdown. If the patient does exhibit symptoms of autonomic dysreflexia, it's an emergency. It's an emergency at that point. So efforts have to be made to lower blood pressure. So you place the patient in a sitting position or elevate his head of bed to a 45-degree angle. If you know what the cause of the stimulation is, so if the patient's bowel is impacted or there's an over-distended bladder, the stimulus should be removed as gently and quickly as possible, and then notify the healthcare provider. Spinal cord injury patients can also experience orthostatic hypotension because vasoconstriction is impaired after a spinal cord injury, and the lack of muscle functioning in the legs causes pooling of blood in the lower extremities. So a sudden change in position from supine to sitting or sitting to standing can cause dizziness and fainting. Another problem or complication is deep venous thrombosis. Decreased blood pressure combined with the lack of muscle movement slows venous return to the heart, so thrombosis can occur in the lower extremities. Compression stockings and SCDs or heparin injections may be needed to prevent DVT from occurring. Infections such as respiratory infections can occur because of impaired respiratory muscles and a decreased cough and shallow respirations, especially with patients with high spinal cord injuries leave them at risk for respiratory infections. Other things like urinary catheters, because of loss of bladder control, also is a risk factor for infection. Patients with spinal cord injuries are also at risk for skin breakdown because of the lack of sensation and the inability to move to reposition oneself. The patient is at greater risk for skin breakdown and pressure ulcers. So it's important to provide meticulous skin care with regular inspection, repositioning, and pressure relieving devices to prevent skin breakdown. Patients with spinal cord injuries can also be at risk for renal complications such as urinary reflux from the bladder to the kidney because of impaired bladder function. Catheterization and immobility predisposes the patient to bladder infections, and then the infections can travel up the ureters to the kidneys. Permanent kidney damage may eventually occur from such infections. And then heterotropic ossification is also a complication. In heterotropic ossification, there's a bony overgrowth that can invade the muscle because of the long-term immobility. So nurses need to be aware of that and inspect joints for muscles for swelling, warmth, and redness, and decreased range of motion of the extremities to detect the ossification that may be occurring. Okay, as far as nursing management goes of patients who have spinal cord injuries, first of all, assessment. There should be continued assessment for signs of decreased oxygenation, blood pressure instability, infection, skin breakdown, GI or nutritional problems, and urinary problems. A daily review of systems should be done regarding the patient's physical status. If they have a tracheostomy tube, of course, you would assess that and take care of that. Monitor traction devices and pins for signs of injury if they have any kind of traction. Assess for correct placement and use of sequential compression devices or compression stockings to prevent DVT. Manage the indwelling catheter. Monitor for infections. Make sure that the catheter is working well so the patient does not experience autonomic dysreflexia if they have an injury at T6 or above. Monitor their IV site. If they have a feeding tube, you would manage that as well. Nursing diagnoses that are appropriate for patients with spinal cord injuries. There are quite a few. We, of course, would first of all have impaired gas exchange related to diaphragm paralysis or retained secretions, impaired physical mobility related to vertebral column instability, disruption of the spinal cord and traction, decreased cardiac output related to hypotension and decreased muscle action causing venous pooling, imbalanced nutrition less than body requirements related to an increased metabolic demand from healing injuries. Let's see here. Slowed GI motility and inability to feed self. Constipation related to a lack of bowel innervation and decreased fluid intake as well as immobility. Impaired urinary elimination related to decreased innervation of the bladder. Constipation related to loss of nerve stimulation and due to immobility. Pain related to muscle spasms. Risk for autonomic dysreflexia related to reflex stimulation of the sympathetic nervous system. Risk for impaired skin integrity related to immobility and loss of sensation. Risk for ineffective coping related to a loss of control over bodily functions and altered lifestyle secondary to paralysis. Disturbed body image related to paralysis and loss of control over bodily function. Interrupted family processes related to change in role within the family because of neurological deficits, and grieving related to neurological deficits and changes in roles and lifestyle. As far as planning, implementation, and evaluation, specific individual expected outcomes are written for each of the nursing diagnoses based on the assessment data that's gathered. Long-term goals are considered, and planning for rehabilitation begins during hospitalization. The patients will be transferred often to rehabilitation facilities for intensive rehab and retraining for activities of daily living once the patient's physical status has stabilized and they no longer require hospitalization. Care for the patient with a spinal cord injury depends upon the level of the injury. When a stabilization device is placed on the head to stabilize the cervical spine, of course, then we would assess and care for pin sites every shift initially, and then as they stabilize twice a day. Sterile technique is used and is performed according to agency policies. Solutions such as sterile normal saline are used for cleaning the pin sites, and antibiotic ointment may be applied. Weights for cervical traction using the the Crutchfield tongs must be kept freely hanging to be effective, and traction pulls should never be interrupted. Tongs may be in place for up to 4 weeks. Okay, and then during rehabilitation, there's a full team of professionals that's involved in the care of the patient during the rehabilitation. Physical therapists, occupational therapists, psychologist, physician or healthcare provider, respiratory therapist, pharmacist, and other ancillary personnel work collaboratively to plan the patient's care. The patient and family are very integral in helping to participate in this planning process. There are a lot of robotics and computerization instruments out there now that are being trialed in the hope that someday patients will be able to walk again. So you'll want to keep track of new developments in this particular area. When the patient is in rehab, communication between team members is crucial, and when the patient is discharged, all plans and specific requirements for the patient's care must be shared with the home caregivers and the home care nurses to provide for continuity of care. Let's take a look at one of the questions. A 40-year-old man with a T4 spinal cord injury suddenly complains of severe headache, increased pulse rate, sweating and flushing above the level of spinal cord lesion, and goosebumps below the level of injury. What immediate nursing actions should be included? Select all that apply. Place flat in bed, identify the cause of the stimulation, decrease blood pressure, provide measures to facilitate bowel movement, and clamp an indwelling catheter. Okay, the answers would be identify the cause of the stimulation, decrease their blood pressure, and provide measures to facilitate bowel movement. First, we would identify the cause. And causes could be distended bladder, bowel impaction, pressure to the skin. So we would decrease the blood pressure by elevating the head of the bed, not laying them flat. And then try to decrease the blood pressure, and also institute measures to evacuate the bowel and check for distended bladder. The nurse keeps the post-craniotomy patient's neck in midline position and ensures that there is no excessive hip flexion. The rationale for the nurse's action would be that this position, A, restores neutral position of the joints, B, prevents a further increase in intracranial pressure, C, promotes comfort and rest, and D, prevents the formation of blood clots. And the answer is going to be, that's not right. It should be B. D should be disappearing as well. Number 2 is the correct one because it's going to prevent an increase in intracranial pressure by facilitating venous drainage from the skull. So it'll decrease intracranial pressure. There, that's better. I like that better. Okay, let's take a look at back pain and ruptured intervertebral disc or slip disc. On-the-job accidents and resultant trauma is often a cause of back pain. Obesity and lack of exercise, poor lifting and moving techniques can also contribute to the stress placed on the back muscles and can result in an injury. Exercise promotes good muscle tone, so treatment of back pain often is referred first of all to physical therapy to improve the musculature and be able to get those vertebrae back into position. Causes of musculoskeletal back pain include acute lumbosacral strain, instability of lumbosacral spine, arthritis of the spine, intervertebral disc degeneration and spinal stenosis, and herniation of the intervertebral disc. The bodies of the spinal vertebrae lie flat on one another like a stack of coins. So between those vertebral bodies there's a disc of fibrous cartilage filled with gelatinous substance that acts as a cushion to absorb shocks in the spinal column. If the gelatinous disc becomes ruptured by an injury, such as a strain when lifting a heavy object, the disc may rupture and part of its contents squeezes out from between the vertebrae, and disc fragments may lodge in the spinal canal. The compression on the adjacent nerve root will cause pain. Okay, and when the protein from the disc content leaks out into the canal, the body perceives it as a foreign substance and causes inflammatory response, and the pain also results from that. The person suffers on what is sometimes called a slipped disc or a herniated nucleus pulposus. Acute back pain usually occurs from activity and puts stress on the tissues of the lower back. It also can be as a result of muscle spasms and usually is self-limiting and resolves within about 4 weeks. Chronic back pain is defined as pain that lasts for more than 3 months or has repeated episodes. Chronic back pain can be caused by degenerative disc disease or osteoarthritis, but it can also be caused by a lack of exercise, a prior injury, and obesity. The most common sites of disc rupture are L4-5 and L5 and S1. Herniation can also occur in C5, C6, and C6, C7. The signs and symptoms are pain radiating down the sciatic nerve into the buttock and below the knee. There may be muscle weakness and paresthesia. If the cervical disc is herniated, it can cause pain in the neck and the shoulders that radiates down the arm with subsequent numbness and tingling in the hand. Diagnosis is based on history and physical exam. There's a straight leg raising test is often used for low back pain. Patient is supine and the leg is raised off the bed or exam table with the whole leg straight. If low back pain occurs, the test confirms a disc problem. Reflexes may also be decreased or absent, and patients may experience muscle weakness or paresthesia in the legs or feet. If conservative therapy is not working, they may have diagnostic tests like X-rays, MRI, or CT scan, or an electromyogram to determine the degree of nerve irritation. Treatment initially is conservative. If there's no sciatic pain, bed rest is not recommended. If there's sciatic pain, then bed rest may be recommended for 2 or 3 days. Ice packs are applied for 5 to 10 minutes at a time each hour for the first 48 hours to reduce muscle spasms in the back, and then after 48 hours, heat may be more helpful because it helps to relax the muscles. Ultrasound treatments can also be done. Heating pads, hot packs, and hot showers work well, also to relax muscles. Studies show that wearing a portable heat wrap decreases pain moderately, and even more than routine taking of ibuprofen. There are transcutaneous electrical nerve stimulation devices that may also help relieve the patient's pain. Back strengthening exercises are prescribed as soon as possible after the acute symptoms subside. And these exercises, like I said, are usually supervised by a physical therapist. The patient is cautioned not to lift anything heavier than 2 to 5 pounds and not to twist when reaching for things. Patients should be up and around moving frequently rather than sitting for long periods. And for women, high heels are not to be worn because that puts more stress on the lower back. Swimming and walking for short distances may be beneficial. Again, standing for long periods should be avoided. And if it's necessary, they should shift their weight from one foot to the other frequently. Some patients may be referred to treatment by a chiropractor. The chiropractic treatments are most effective if the pain has been present for less than 16 days. Here you see a picture of a herniated disc. You can see where the compression of the spinal cord has occurred and the portion of the disc has herniated out from between the vertebral column. Other complementary treatments for back pain, besides chiropractic, acupuncture has been found to be helpful in some instances for chronic pain. Acupressure relieves muscle spasms. Massage therapy can also be effective in relieving muscle spasms. And some patients have found that gentle yoga movements also have been successful in helping to relieve pain. Surgical procedures that can be done to relieve back pain: discectomy, spinal fusion, and laminectomy. Discectomy is performed to decompress the nerve root and uses a very small incision through which the herniated intervertebral disc material is dissected and removed. It's minimally invasive and can be done as an outpatient. A spinal fusion is necessary when patients need stabilization of the spine. So a piece or several pieces of bone are removed from the iliac crest and are grafted onto the vertebrae to strengthen them. They may also have metal rods and screws placed to decrease spinal motion and irritability. And then a laminectomy may be performed for conditions other than a ruptured disc. For example, if there's a degenerative disease of the spine or a fracture of the spine. And at this point in laminectomy, the lamina of the vertebra is removed, and then the compression is alleviated on the nerve root, and pain is relieved by that way. Nursing management Preoperatively, we do a baseline neurological assessment and document the same. Pre-op care is pretty basic. It's the same as it is for any other type of surgery. Postoperatively, the major concern after the spinal fusion, laminectomy, or discectomy is to keep the spinal column in alignment so it can heal. So pillows are placed under the thighs when the patient's on his back and between the legs when he's on his side to maintain correct spinal alignment and decrease pressure to the back. Patient can be turned to side by log rolling to avoid using or twisting the spine. Of course, we always check the physician's orders to make sure if that's okay. Patient may have a back brace or corset prescribed to support the spinal column, especially when they're getting up. Patient should not be allowed to sit for extended periods of time. He should get up and walk or lie down, as well as standing for long periods of time also is discouraged. Pain control is important immediately after the surgery. If the patient's an inpatient, they may have a PCA pump. If not, they may be put on oral analgesics such as hydrocodone or oxycodone with acetaminophen, and muscle relaxants may be given as well. In this picture you can see the staff is demonstrating appropriate log rolling procedure because we want to prevent the patient from twisting, his spine, so he basically will be repositioned from side to side using the log rolling technique. You can kind of see where the patient has the pillow between his legs to maintain good alignment. So guidelines for patients with low back pain or spinal surgery: do bend knees with back straight and crouch to lift an item off the floor. Carry items close to the center of your body. Perform back exercises twice a day. Periodically review the correct way to do them. Maintain appropriate body weight and lose weight if overweight. Use a lumbar pillow or roll when sitting, and particularly when driving for long distances. Stop and walk around at least every 2 hours when on long trips, and consider how to safely perform a task before starting to do it. Do not lean over without bending the knees. Reach to lift items or lift heavy items higher than the elbows. Stand or sit for long periods of time. Sleep with legs out straight without pillow cushioning under the thighs or between the legs when on the side. Bend from the waist to pick up an item, or twist to the side to lift things such as groceries or things in the car or the trunk. Okay, let's take a look at this. Gus Barini is a 40-year-old truck driver who received a severe spinal injury when he was shot in the back by a hitchhiker. The bullet severed the spinal cord at the 6th thoracic vertebra. What kinds of activities should Mr. Barini eventually be able to perform? How would you plan his care during the acute stage of his illness so that efforts at rehabilitation might be successful? And what other members of his healthcare team might participate in his care and rehabilitation? So if we look at the table and table 22-1, level of spinal cord damage, function present, activities possible, on page 512, he sustained a severed spinal cord at 6th thoracic vertebra. So from T1 to T10, the patient should have normal arm movement and strength, loss of bowel, bladder, and sexual function. They may achieve walking with brace, able to perform ADLs, and achieve vocational and recreational goals. So we know approximately what type of activity the patient should be able to perform. During the acute care stage of his illness, what would we focus in on? Well, first of all, we're going to focus in on 4 things. We're going to focus in on saving the patient's life, preventing further injury to the cord by careful handling of the patient. He will have his repair as much damage to the cord as possible, and then establish a routine of care that will improve and maintain the patient's state of health and prevent complications so that eventual physical, mental, and social rehabilitation is possible. So we would look at respiratory management, immobilization, urinary management, psychological care, and sexual concerns. And we would then monitor for complications such as spinal shock, muscle spasms, autonomic dysreflexia, orthostatic hypotension, deep venous thrombosis, infection, skin breakdown, and any other renal complications. As far as what other members of the healthcare team might participate in his care and rehabilitation, we kind of went over that too briefly. The physical therapist, occupational therapist, psychologist, physician, respiratory therapist, pharmacist, and other ancillary personnel, so perhaps, like dietitian, would be helpful in participating in his care and rehabilitation.